Welcome back to the deep dive. Today, we're tackling something really essential and complex. We're talking high-risk pregnancy conditions.
Yeah, it's a critical area.
And we're not just listing them off. We want to get into how the pathophysiology, and why the causes, the risk factors.
And crucially, the management, what happens moment to moment, the nursing interventions, the medications, that's where lives are often saved.
Absolutely. We're defining high risk here as anything that seriously threatens the mother, the baby, or sometimes both.
Right. And the sources we looked at really hammer this home. It's not just about the doctor's diagnosis. It takes this incredibly coordinated effort. Medical teams, nursing staff, all working together perfectly. These are often real emergencies. Precision is key.
The urgency really hits you when you see the numbers, especially for hypertensive disorders. That's where we'll start.
Definitely. Hypertension in pregnancy, it's the most common medical issue globally. And it's a huge factor in, well, bad outcomes, perinatal morbidity and mortality, often because of problems with the placenta or leading to premature birth.
And the statistic that stands out.
It's stark. Preeclampsia and eclampsia account for something like 10 to 15% of all maternal deaths worldwide.
Wow.
Yeah, that's over 50,000 mothers dying every single year. It's more than just a complication. It's a global health crisis hiding in plain sight.
Okay, that definitely sets the stage. Let's dive into these hypertensive disorders, starting with preeclampsia. All right, preeclampsia. The sources define it as this progressive disease affecting multiple organs. New high blood pressure showing up after 20 weeks. Before we get into the mechanics, who's most at risk here, the list seems quite broad.
It really is. You've got the factors people might expect. Being pregnant for the first time, that's a big one. Being older, say over 35. Certain ethnic backgrounds, like African-American women, unfortunately have a higher risk. And then chronic health issues, existing high blood pressure, obesity, diabetes.
Right.
Also things like a history of blood clotting disorders, thrombophilia, or carrying multiples like twins or triplets. And interestingly, a family history of preeclampsia definitely bumps up the risk.
You mentioned some maybe less obvious factors, too.
Yeah, a couple of surprising ones. Using IVF, in vitro fertilization, seems to increase the risk somewhat. And one that really caught my eye was pregnancy onset snoring.
Snoring, really?
Yeah, it suggests maybe some underlying changes in breathing, oxygen levels that could be adding to vascular stress. It's fascinating.
And there was something about the father's role, too, a genetic link.
That's a really compelling piece. Research suggests that men who have fathered a preeclamptic pregnancy have a higher chance of doing so again, even with a different partner.
Wow.
It strongly points to some kind of paternal contribution, maybe influencing how the placenta develops. And the placenta, well, that's really the heart of the problem in preeclampsia.
Okay, let's clarify the terms before we dig into that root cause. How do we categorize these conditions?
Right, so first you have gestational hypertension. That's high blood pressure over 490 starting after 20 weeks. But crucially, without protein in the urine or other signs that organs are being affected.
Just the high BP.
Exactly. Then there's chronic hypertension, which affects maybe 4 or 5% of pregnant women. Ideally, you want that managed before pregnancy. If it's not controlled, it carries risks like placental abruption, we'll get to that, or developing preeclampsia on top of the chronic hypertension.
Superimposed preeclampsia.
Right. And risks for the baby, too, like growth restriction, IUGR, or being born too early.
So preeclampsia is different because it's not just high blood pressure. It involves this systemic organ issue. Why does that happen? You said the placenta is key. What's the actual pathophysiology?
It all starts really early, right around implantation. And the problem doesn't truly go away until the placenta is delivered. In a healthy pregnancy, these little arteries in the uterus, the spiral arteries that feed the placenta, they undergo this amazing transformation. It's called vascular remodeling.
Okay.
They get much wider, thicker, almost floppy to handle the massive increase in blood flow needed.
Like upgrading a small road to a superhighway for all the nutrients and oxygen.
Exactly like that. But in preeclampsia, this remodeling either doesn't happen right or it only happens partially. The arteries stay narrow and stiff.
So the highway doesn't get built.
Pretty much. And that leads directly to less blood flow. To the placenta, decreased placental perfusion, and the placenta becomes hypoxic, starved for oxygen. This stressed out placenta then starts releasing harmful substances into the mother's bloodstream.
And those substances are what cause the widespread damage.
That's right. They attack the lining of the mother's blood vessels everywhere, the endothelial cells. This widespread endothelial cell dysfunction is the trigger for almost everything else we see. It causes two huge problems at once.
Okay, what are they?
One, generalized vasospasm. All the blood vessels constrict, tightening up. This dramatically increases peripheral resistance, and that's what causes the signature high blood pressure.
Makes sense.
2. The vessel lining becomes leaky. Increased endothelial permeability. Fluid and protein start seeping out of blood vessels into the tissues. This causes swelling, edema, and it also means less fluid inside the vessels, which further reduces blood flow to the tissues. Decreased tissue perfusion.
Wow, that's a cascade. So let's follow that decreased blood flow. Where does it cause the most obvious problems? Which organs?
Okay, let's trace it. Start with the kidneys. Less blood flow damages the filtering units, glomeruli. They start leaking protein. That's the proteinuria we look for in the urine.
Yeah.
And they don't filter as well, leading to less urine output, oliguria.
Right.
Then the liver. Decreased perfusion causes ischemia, liver cell damage. We see that as elevated liver enzymes in blood tests. Clinically, this often shows up as severe nausea, vomiting, and that really characteristic intense pain in the upper abdomen, either in the middle, epigastric, or under the ribs on the right side, RUQ pain.
The RUQ pain sounds serious, like the liver itself is swelling.
Exactly. It suggests the liver capsule is stretching. It's a major danger sign, a huge red flag.
Okay, kidneys, liver. What about the brain?
In the CNS, the central nervous system, that vasospasm affects the brain too. It can cause cortical brain spasms. The symptoms: persistent headaches, really exaggerated reflexes, we call that hyperreflexia, and in the worst cases, seizures. That's when it becomes eclampsia.
And the eyes. People report vision changes.
Yes, even the eyes aren't spared. Spasms in the tiny arteries of the retina can cause blurred vision or scotoma, seeing flashing lights or spots.
This explains so much. It's truly a multi-system disease. So how do doctors and nurses tell the difference between, say, a milder case and one that's becoming life-threateningly severe?
It really comes down to specific thresholds and those signs of organ damage we just talked about. So preeclampsia without severe features generally means the blood pressure is high, between 1490 and just under 160/110. There's proteinuria, maybe some swelling. The disease is there, but it seems relatively stable for the moment.
But once you cross certain lines,
Then you're in the preeclampsia with severe features category. That's defined by blood pressure consistently at or above 160/110, or the presence of any of those danger signs we discussed. Very low platelet count, signs of liver damage like those high enzymes, kidney problems like rising creatinine or low urine output, persistent neurological symptoms like bad headaches or vision changes, or fluid in the lungs, pulmonary edema. Any one of those flips the switch to severe.
and that means immediate intensive management.
Okay, so given how quickly things can escalate, what are the absolute must-do nursing assessments when someone comes in with suspected preeclampsia?
Vigilance is everything. Continuous, careful assessment. First, you need an accurate BP reading, usually done consistently, maybe while the patient is resting on their side. Second, checking for protein in the urine. A 24-hour collection is the gold standard, but a dipstick gives a quick idea. But honestly, the most critical piece is often the neurologic assessment.
Why the neurocheck specifically? Because it's often the earliest warning sign that eclampsia, a seizure, might be coming. The nurse has to meticulously check the deep tendon reflexes, or DTRs, usually the biceps and the knee-jerk reflex at the patella.
And you grade those reflexes.
Yes, on a scale typically 0 to 4 plus Sale. What you're looking for is hyperreflexia reflexes that are graded as 3 plus or 4 plus Sale, meaning they're brisker than normal or even exaggerated. If you see that, especially if it comes with clonus.
Clonus, what's that?
Clonus is when you quickly dorsiflex the foot, push it upwards, and instead of just returning, the foot beats rhythmically back against your hand, maybe a few times. It's another sign of extreme neuromuscular irritability. High DTRs plus clonus means the CNS is very hyped up, very close to seizing.
So jumpy reflexes are a serious warning.
A huge warning. And alongside checking reflexes, the nurse is constantly asking about those other warning signs. Are you having a headache that just won't quit? Any changes in your vision, blurring, spots? Any pain up here? Pointing to the epigastric or RUQ area. These subjective symptoms are critical pieces of the puzzle. They might be the last warnings before things go really wrong.
When the blood pressure gets dangerously high, into that severe range, you have to use antihypertensive drugs, right? Like labetalol, hydralazine, nifedipine.
Yes, you have to bring the pressure down. But there's a crucial catch, a real paradox here.
What's that?
You absolutely cannot lower the blood pressure too quickly or too far.
Why not? Isn't lower better?
Not necessarily for the baby. Remember, the blood vessels supplying the placenta are already narrowed and constricted because of the disease. They actually rely on that higher maternal blood pressure to force enough blood through to the fetus. If you drop the mother's pressure too aggressively, you can suddenly cut off the baby's blood supply.
Oh, wow. So you could cause fetal distress by treating the mother's BP too much.
Precisely. It's a very delicate balancing act. The goal is control, bringing the pressure down to a safer level, like maybe below 160, 110, but not necessarily making it normal. You have to protect uteral placental perfusion at all costs.
That balancing act feels even more intense when you get to eclampsia, the actual onset of seizures or coma.
Eclampsia is the ultimate crisis, and it's vital to remember it can happen anytime before labor, during labor, or even after delivery.
Really? After the baby's out?
Absolutely. About 30% of eclampsia cases, and HELLP syndrome too, actually occur in the postpartum period, usually within the first 24 to 48 hours. So the intense monitoring doesn't stop just because the delivery is over.
Okay. The main treatment, the cornerstone for preventing and treating seizures, is magnesium sulfate MgSO4. It's important to stress this isn't lowering blood pressure, right?
Correct. MgSO4 is primarily a central nervous system depressant. It works to calm that hyperirritable state in the brain to prevent seizures or stop them if they're happening.
Yeah.
It's not an antihypertensive. And administering it, well, it's incredibly high-stakes nursing. Precision is everything.
Let's walk through the calculation example provided. It really shows how exact this needs to be. Say the order is for a 4-gram loading dose, IV, over 20 minutes. The bag comes as 4 grams and 100 milliliters fluid, like lactated ringers.
Okay. So the nurse needs to figure out the pump rate in ml per hour. If 100 milliliters needs to go in over 20 minutes, well, 20 minutes is 1/3 of an hour. So in a full hour, you'd give 3 times that volume.
Right, 100 milliliters times 3. So the pump rate for the loading dose is 300 milliliters per hour.
Exactly. Flawless calculation needed. Then comes the maintenance dose, often ordered at something like 2 grams per hour. Let's say the maintenance bag is 20 grams of mag sulfate mixed in 250 milliliters of LR.
Okay.
The nurse has to calculate how many ml deliver that 2 grams each hour. If there are 20 grams in the whole 250 milliliter bag, then 2 grams is 1/10 of the total drug amount.
So you need 1/10 of the total volume.
Right. 1/10 of 250 ml is 25 milliliter. So the maintenance infusion rate is set at 25 milliliter per hour. You absolutely cannot afford errors with these calculations.
Why such intense focus on the math? Because magnesium sulfate has a really narrow safety margin, doesn't it?
Dangerously narrow. The therapeutic range where it prevents seizures but doesn't cause harm is very tight. Toxicity is a constant threat because it's depressing the whole central nervous system. Nurses have to be hyper alert for signs of overdose.
And what's the earliest sign?
The earliest, most common sign of magnesium toxicity is loss or significant decrease in the deep tendon reflexes, DTRs. If those reflexes become sluggish or disappear entirely, the mag level is likely too high. That's the first alarm bell.
And if it gets worse, what are the life-threatening signs?
If the level keeps rising, the patient can become confused, lethargic, their speech might slur, but the most critical danger is respiratory depression. Their breathing rate slows down, often below 12 breaths per minute. Oxygen saturation drops. Ultimately, it can lead to full respiratory arrest and then cardiac arrest. We generally consider a blood level over about 8.4 mg/dL to be in the toxic range.
So if the nurse sees those DTRs disappear or the respiratory rate drops below 12, what's the immediate action?
Stop the infusion. Immediately turn off the magnesium sulfate, and you must have the antidote ready at the bedside at all times.
The antidote is?
Calcium gluconate. It's given as 1 gram IV, usually pushed relatively slowly, over about 3 minutes. It directly counteracts the effects of the magnesium on the muscles and nerves.
Okay, let's shift to the actual seizure. Eclampsia happens, the mother starts convulsing. What's the immediate step-by-step nursing response during the seizure?
First, stay calm, but act fast. Call for help immediately. You need more hands. The absolute priority is safety and airway. Turn the patient onto her side, the recovery position. This helps keep the airway clear and prevents aspiration.
Yeah.
Make sure oxygen is available and applied, have suction ready, get the side rails up and pad them if possible to prevent injury. But, and this is crucial, do not restrain the patient while she's seizing. Trying to hold her down can cause injuries like fractures.
Just protect her from injury.
And observe. Yes, observe carefully. Note the exact time the seizure started and how long it lasts. If you witness it or it's ongoing, and if IV access is secure, the standard order is to administer that emergency bolus of magnesium sulfate, usually 4 to 6 grams, given IV over about 5 minutes to stop the seizure activity.
Once the seizure stops, the really intensive care begins. What does that involve?
It's usually one-to-one nursing care at this point. While the patient is unconscious or in that post-seizure, post-ictal state, you're assessing constantly. You need to check for signs the baby is in distress, and crucially for signs of placental abruption, which can be triggered by the seizure.
How do you check for abruption?
You frequently palpate the abdomen, feel the uterus. Is it becoming hard, rigid, tender? That suggests bleeding behind the placenta. You also check for vaginal bleeding, maybe every 15 minutes initially. A Foley catheter goes in immediately for strict intake and output INO monitoring. Good urine output is vital. It shows the kidneys are working and helps clear the magnesium.
And checking the lungs.
Absolutely. Listen to the lungs frequently for crackles or signs of fluid buildup. Pulmonary edema is a risk. And finally, you control the environment. Keep the room quiet, dim the lights, minimize disturbances. You want to reduce any stimulation that could potentially trigger another seizure.
When is delivery finally the answer?
Ideally, you stabilize the mother first. If possible, she should be transferred to a hospital with high-level intensive care and neonatal support before delivery. Birth is usually planned once her vital signs are stable, her urine output is good, and both mother and baby seem reasonably stable and not hypoxic. Securing the mother's safety comes first. #tag40FAIF, HELLP syndrome, and postpartum resolution.
Okay, let's talk about the most severe variant of preeclampsia, HALLP syndrome. The sources call it a laboratory diagnosis happening in about 10% of severe cases, and it involves the liver.
Yeah, HELLP is basically preeclampsia on overdrive, causing specific types of organ damage much faster. It's diagnosed based on 3 key lab findings, which make up the acronym. H is for hemolysis. Red blood cells are being destroyed. EL is for elevated liver enzymes, AST, ALT showing liver cell injury, and LP is for low platelet count, typically below 100,000.
How does the underlying preeclampsia process lead to these specific problems?
It's that severe endothelial dysfunction getting worse. The intense vasospasm damages the lining of tiny blood vessels. As red blood cells try to squeeze through these damaged narrowed vessels, they get physically torn apart. That's the hemolysis. The damage in the liver vessels leads to clots, blockages, and liver tissue death, causing the elevated enzymes and that severe RUQ pain. And platelets get used up trying to form clots in all these damaged areas, leading to low platelet count.
What's tricky about diagnosing HELLP, sometimes the symptoms aren't classic preeclampsia, right?
That's the real danger. Patients might just feel generally unwell, like they have the flu malaise, or they present mainly with that bad epigastric or RUQ pain. Their blood pressure might not even be sky high initially. And there's often this weird cyclical pattern. Symptoms get worse at night and seem a bit better during the day. This can unfortunately delay diagnosis sometimes.
Management sounds like it has to be in the ICU.
Absolutely. Intensive care setting. You need magnesium sulfate for seizure prevention, just like in severe preeclampsia. You need careful blood pressure control, often with IV meds like hydralazine or labetalol, maybe fluid replacement. And then, delivery is the definitive treatment. The timing and method induction versus C-section need careful planning. But that low platelet count, it makes things like epidurals really risky due to the potential for bleeding around the spinal cord.
You mentioned earlier that the danger doesn't end with delivery. What about postpartum?
Right, because of that significant risk, up to 30% of postpartum eclampsia, or HELLP, magnesium sulfate is usually continued for at least 12 to 24 hours after the birth. The patient stays in the hospital for close monitoring, often for 72 hours or more, watching for signs that the disease is finally starting to resolve.
What are those signs? How do you know things are getting better?
The big one is usually a significant increase in urine output diuresis. That often starts within 48 hours postpartum. Along with that, you should see the blood pressure gradually coming down, less protein in the urine, and those abnormal labs normalizing platelets start to rise, liver enzymes begin to fall.
Okay, wrapping up hypertension. Is there any surefire way to prevent preeclampsia or HELLP from happening in the first place?
Unfortunately, no, not reliably. The best defense is good, early prenatal care, paying close attention to blood pressure trends and checking urine for protein at every visit. For women identified as being at high risk, low-dose aspirin, just 81 milligrams a day, might be recommended. But things people used to try, like strict salt restriction or taking fish oil supplements, the evidence shows they just don't work.
And for women who go through severe preeclampsia or HELLP, what are the long-term health implications?
They definitely face a higher risk of it happening again in future pregnancies. But beyond that, they also have a significantly increased lifetime risk of developing chronic hypertension and cardiovascular disease later on. So surviving preeclampsia means lifelong awareness managing weight, BP, lifestyle factors becomes even more important. ###be hemorrhagic conditions of early and late pregnancy.
Let's switch gears now to another major category of high-risk conditions: bleeding or hemorrhage. This can be immediately life-threatening, starting with early pregnancy bleeding, specifically spontaneous abortion or miscarriage pregnancy loss before 20 weeks. We know genetic issues are common, but what about maternal factors?
There's quite a range. It could be structural problems with the uterus, like an incompetent cervix that opens too early, or abnormalities in the uterus shape itself. Or it could be systemic maternal health problems, poorly controlled diabetes, kidney disease, thyroid issues, even severe infections. Hormonal imbalances can play a role too. And substance use, like crack cocaine, is also implicated.
What's the general approach to treatment, and what's that one critical nursing step if the woman is Rh negative?
Treatment really depends on the specific situation. Is it just a threatened miscarriage, or is it inevitable or already happened? It might involve bed rest, avoiding intercourse, monitoring the bleeding. Sometimes hospitalization for IV fluids is needed. If tissue remains in the uterus, a procedure called a dilation and curettage, D&C, might be done to clear it out. And yes, absolutely critical. If the woman is Rh negative, she must receive ROGAM anytime there's bleeding to prevent sensitization.
Okay. Then there's ectopic pregnancy, when the embryo implants outside the uterus, usually in the fallopian tube. This can be fatal if it ruptures. How do the symptoms differ from a miscarriage?
There can be overlap, but key signs for ectopic often include missing a period, having a positive pregnancy test, and then developing abdominal pain. The pain is often described as sudden, sharp, maybe localized to one side, but it can be diffuse too. There might be vaginal spotting. Fainting or dizziness can occur if there's internal bleeding.
But there's one symptom that's considered almost classic for a rupture.
Yes, the textbook sign, strongly suggesting internal bleeding from a ruptured tube, is referred shoulder pain. Pain felt up under the shoulder blade.
Shoulder pain. Why?
Because blood accumulating in the abdomen irritates the diaphragm and the phrenic nerve. And that nerve sends pain signals that are felt up in the shoulder area. If you hear that symptom along with the others, you have to suspect a ruptured ectopic.
If it's caught early, before rupture, there's a medical option. Methotrexate. That's a chemotherapy drug, right? So special handling is needed.
Absolutely. Methotrexate requires careful handling. It's given by intramuscular injection. Because it's cytotoxic, the nurse needs to wear double gloves, and everything used, syringe, needles, gloves, must go into a specific hazardous waste container.
And what does the patient need to know about this drug? The education seems really important.
Crucial teaching points. The drug is excreted in urine and stool for several days, so patients need to be careful. Maybe double flush the toilet, avoid splashing to protect others. They must avoid taking folic acid supplements because methotrexate works by blocking folate. They should also avoid significant sun exposure due to photosensitivity and no sexual intercourse until blood tests confirm the pregnancy hormone HCG has dropped to 0, showing the treatment was successful.
If methotrexate doesn't work, or if it's already ruptured, surgery is the next step.
Right. Surgery might involve removing the affected fallopian tube entirely, salpingectomy, or sometimes, if possible, just removing the pregnancy tissue and trying to repair the tube, salpingostomy, to preserve fertility. And again, if the woman is Rh negative, ROGAM is essential after the procedure.
Okay, let's move to bleeding in late pregnancy after 20 weeks. Two big ones here: placenta previa and abruptio placentae. Let's start with previa. What is it?
Placenta previa is when the placenta implants low in the uterus, partially or completely covering the cervix, the opening the baby needs to pass through. It happens in maybe 1 out of 200 pregnancies.
And how does it usually present?
The classic sign is painless, bright red vaginal bleeding. The amount can vary from spotting to heavy hemorrhage. It's classified based on how much of the cervix is covered: marginal, partial, or total previa. We don't always know why it happens, but risks include older maternal age, previous C-sections, or having had multiple prior pregnancies.
There's one absolute rule for managing suspected previa, isn't there? A critical nursing do not.
Yes, this is non-negotiable. Absolutely NO digital vaginal exams, no putting fingers into the vagina to check the cervix until an ultrasound has confirmed the placenta's location and ruled out previa.
Why is that so critical?
Because if the placenta is covering the cervix, even partially, putting fingers up there could puncture the placenta and trigger massive, potentially uncontrollable hemorrhage. It's incredibly dangerous. Once previa is confirmed by ultrasound, management usually involves activity restriction, monitoring, and often planning for a C-section delivery.
Okay, now the other major cause of late pregnancy bleeding: abruptio placentae. placental abruption? This sounds even scarier.
It often is, because it can happen so suddenly and progress so rapidly. Abruption is the premature separation of a normally implanted placenta from the uterine wall before the baby is born.
What causes it?
The exact cause is often unknown, but major risk factors include maternal hypertension, both chronic and preeclampsia, abdominal trauma, smoking, and cocaine use. Having had a previous abruption also significantly increases the risk.
And unlike previous painless bleeding, abruption usually involves
Pain, often sudden, severe abdominal pain, along with vaginal bleeding, though sometimes the bleeding can be hidden behind the placenta. The uterus typically becomes very hard, rigid, and tender, often described as board-like. There might be frequent contractions or uterine irritability.
The risks here for both mother and baby are immediate and severe. How bad can it get?
For the mother, the biggest immediate risk is hypovolemic shock from blood loss. But there's also a high risk of developing DIC, disseminated intravascular coagulation.
DIC again. Why does abruption trigger that?
When the placenta tears away, it releases large amounts of tissue factor, thromboplastin, into the mother's circulation. This kicks off a massive, uncontrolled clotting cascade throughout her body. All the clotting factors get used up trying to form tiny clots everywhere, which paradoxically leads to inability to clot where needed, resulting in uncontrollable bleeding from IV sites, incisions everywhere. It's a clotting and bleeding crisis at the same time.
That sounds terrifying. And for the baby?
The consequences are devastating. Because the placenta is detaching, the baby loses its oxygen and nutrient supply. Fetal distress is almost immediate. Perinatal mortality, the baby dying around the time of birth, is high, maybe approaching 25%. If more than half the placenta separates, fetal survival is virtually impossible. Even babies who survive are at high risk for brain damage due to oxygen deprivation.
So if abruption is suspected, what's the immediate nursing response?
Emergency mode. Continuous electronic fetal monitoring is essential to see how the baby is tolerating it. Check maternal vital signs, constantly watching for signs of shock. Assess the uterus feel for that increasing tenderness and rigidity. Look for signs of DIC, unusual bruising, petechiae, bleeding gums oozing from puncture sites. You need at least 2 large-bore IV lines immediately for fluids and potential blood transfusion. Draw blood for type and cross-match, coagulation studies. Prepare for an immediate delivery, usually an emergency C-section. And have RhoGAM ready if the mother is Rh negative. Hashtag Vatabelic.
Okay, shifting again. Let's talk about blood incompatibility, specifically Rh incompatibility. This is about the mother's blood type being Rh negative and the baby's being Rh positive. How does the problem start?
It starts with sensitization. An Rh negative mother doesn't have the Rh antigen on her red blood cells. If she carries an Rh positive baby, tiny amounts of the baby's Rh positive blood cells can cross the placenta and enter her circulation. This usually happens most significantly at delivery when the placenta separates, but it can happen with any bleeding during pregnancy, miscarriage, or procedures like amniocentesis.
So her body sees these Rh positive cells as foreign.
Exactly. Her immune system recognizes the Rhd antigen as foreign and mounts an immune response, creating antibodies against it. This first exposure, the sensitization, usually doesn't harm the first Rh positive baby.
But the problem is for future pregnancies.
That's right. Once sensitized, the mother has these anti-Rhd antibodies, specifically IgG antibodies, circulating. In subsequent pregnancies, if the baby is again Rh positive, these maternal antibodies can cross the placenta. They then attack and destroy the baby's Rh positive red blood cells.
And what does that destruction do to the fetus?
It causes hemolytic disease of the fetus and newborn, HDFN. The breakdown of red blood cells leads to severe fetal anemia. The fetus tries to compensate by producing more red blood cells, but it can't keep up. The breakdown also releases large amounts of bilirubin. High bilirubin levels can damage the developing brain that's called kernicterus.
And the severe anemia itself causes major problems.
Yes, the profound anemia leads to heart failure. The fetus becomes severely swollen with fluid generalized edema. This condition is called hydrops fetalis. It's often fatal without intervention.
Thankfully, we have a highly effective prevention, RhoGAM. How does it work? And when is it given?
RhoGAM, Rh immune globulin, is basically a concentrated solution of those anti-Rhd antibodies. When it's given to the Rh negative mother, it finds any Rh positive fetal cells that might have entered her circulation and destroys them before her own immune system even notices them. It prevents her from becoming sensitized in the first place.
So it tricks her immune system.
Essentially, yes. The standard protocol is that all unsensitized Rh negative pregnant women receive a dose of RhoGAM prophylactically around 28 weeks of gestation. Additionally, they need a dose after any potential sensitizing event like bleeding, miscarriage, abortion, amniocentesis, trauma, or delivery of an Rh-positive baby, and that post-event dose needs to be given within 72 hours.
Okay, crucial prevention. Let's move to metabolic challenges, focusing on diabetes in pregnancy, whether it's pre-existing type 1 or type 2 or gestational diabetes GDM that develops during pregnancy. What's the core issue pregnancy creates metabolically?
The fundamental problem is insulin resistance. As pregnancy progresses, the placenta pumps out increasing levels of hormones, especially human placental lactogen, HPL, but also cortisol, estrogen, progesterone. These hormones actively interfere with the mother's insulin, making her cells less responsive to it.
So her body needs more insulin just to keep blood sugar normal.
Exactly. It's a naturally diabetogenic state. Most women can compensate by producing significantly more insulin. But if a woman's pancreas can't keep up with this increased demand, her blood glucose levels start to rise, leading to hyperglycemia. If she already has diabetes, her insulin needs will dramatically increase. If she didn't have diabetes before, she might develop GDM.
For gestational diabetes specifically, what's the main reason we need to diagnose and manage it? What are we trying to prevent for the baby?
The primary goal is tight blood glucose control to minimize risks to the fetus. If the mother's blood sugar is high, excess glucose crosses the placenta to the baby. The baby's pancreas responds by pumping out extra insulin. This fetal hyperinsulinemia acts like a growth hormone. Fetal macrosomia of the baby grows unusually large. A macrosomic baby is at much higher risk for birth trauma, especially shoulder dystocia, where the shoulder gets stuck during delivery. This often leads to nerve damage or fractures for the baby and increases the likelihood of needing a C-section for the mother. High maternal glucose can also cause other issues, like neonatal hypoglycemia after birth.
So how is GDM typically screened for?
Standard screening usually happens between 24 and 28 weeks gestation. It typically starts with a 1-hour glucose challenge test, GCT. The woman drinks a sugary drink containing 50 grams of glucose, and her blood sugar is checked 1 hour later. No fasting required for this initial screen.
And if that's high?
If the 1-hour result is above a certain threshold, commonly 130 or 140 milli-GDL, depending on the lab, then she needs a follow-up diagnostic test. The 3-hour oral glucose tolerance test, GTT. For this one, she fasts overnight, gets a baseline blood draw, drinks a 100-gram glucose load, and then has her blood drawn again at 1, 2, and 3 hours post-drink.
And how is GDM diagnosed from that?
GDM is typically diagnosed if 2 or more of those 4 blood glucose values, fasting, 1 hour, 2 hour, 3 hour, are elevated above specific cutoffs.
Okay. And finally, managing labor for a woman who is insulin dependent, whether type 1, 2, or GDM, requiring insulin. That sounds intense.
It requires extremely close monitoring. Usually the mother is kept NPO, nothing by mouth, during active labor except maybe ice chips, to better control glucose levels. Her blood glucose is checked very frequently, often every single hour.
Every hour? Wow.
Yes, because labor itself affects glucose levels, and you need tight control. She'll typically be on an IV insulin drip, and the rate of that drip is adjusted hourly based on those blood sugar readings. The goal is to keep her glucose in a very narrow, near-normal range.
Why is that so critical right at the end?
To prevent maternal hyperglycemia during labor. If the mother's sugar is high, the baby's pancreas is still pumping out lots of insulin. Then, immediately after birth, when the umbilical cord is cut, the baby's glucose supply from the mother suddenly stops, but its own high insulin levels persist. This can cause a rapid, dangerous drop in the newborn's blood sugar, neonatal hypoglycemia, which can cause seizures or brain injury if not treated quickly.
And what happens to her insulin needs right after delivery?
They plummet. As soon as the placenta is delivered, those anti-insulin hormones are gone. Her insulin resistance drops dramatically. So postpartum, her insulin needs usually decrease very rapidly. She'll typically be monitored closely with frequent blood sugar checks and put on a sliding scale insulin regimen to figure out her new, much lower baseline requirements. #7, perinatal loss and fetal neonatal risks.
Let's touch on multiple gestation twins, triplets, etc., which we know is a high-risk situation. What's driving the increase in multiples we've seen?
It's mainly 2 things. First, women are having children later. An older maternal age naturally increases the chance of releasing more than 1 egg. Second, and probably more significantly, is the increased use of assisted reproductive technologies, RRT, things like IVF, and especially ovulation induction medications, which directly stimulate the ovaries to produce multiple eggs.
Are the risks the same for all types of twins? Like fraternal versus identical?
No, there's a big difference. Fraternal or dizygotic twins come from 2 separate eggs fertilized by 2 separate sperm. They're genetically like siblings. They usually have their own placentas and amniotic sacs, diamniotic or day-day. The risks are mostly related to carrying the extra weight and volume, increased risk of preterm labor, gestational diabetes, preeclampsia for the mother, maybe more discomfort like back pain earlier.
But identical twins.
Identical or monozygotic twins come from a single fertilized egg that splits. The risks depend heavily on when that split occurs, specifically whether they end up sharing a placenta, monochorionic, and a dominant amniotic sac, monoamniotic.
And sharing is riskier.
Much riskier. Monochorionic twins who share a placenta have significantly higher mortality rates, maybe 3 to 10 times higher than dizygotic twins. They are at risk for major complications arising from unequal blood flow across placental connections, the most serious being twin-to-twin transfusion syndrome.
TTTS.
TTTS. Yeah, where one twin, the recipient, gets too much blood flow, becomes overloaded with fluid, polycythemic, and can develop heart failure. The other twin, the donor, doesn't get enough blood, becomes anemic, growth restricted, and can also die. It's often fatal for both if untreated.
And if they share a sac, too.
Monochorionic MOMO twins are the highest risk because, in addition to TTTS risk, their umbilical cords can easily become tangled or knotted, cutting off blood supply suddenly. They also have a higher rate of congenital anomalies. If one twin dies in utero after 20 weeks, the surviving monochorionic twin is also at high risk for neurological damage or death.
Okay. This leads us to our final and undoubtedly most difficult topic: perinatal loss. The death of a baby before birth or in the first year. When all the medical interventions fail, the focus shifts entirely. What's the core principle of care then?
It's a profound shift from life-saving to providing compassionate, respectful, end-of-life care. The absolute cornerstone, emphasized in the sources, is to acknowledge the infant as a person. This baby was born, this baby lived, even if briefly, and this baby died. That recognition is paramount for the parent's grieving process.
How is that acknowledgement put into practice?
It means using the baby's name if the parents have chosen one, offering the parents the opportunity to see, hold, bathe, and dress their baby, providing quiet, private time for them to be with their child. It's about creating memories and validating the baby's existence and the parent's loss.
And a key part of creating those memories is the memory packet. Why is that so important?
Because when parents leave the hospital after a loss, their arms are empty. The memory packet provides tangible, physical items that serve as proof of their baby's existence. Grief can cloud memories, but these items remain. They become incredibly precious touchstones for remembrance and healing in the weeks, months, and years to come.
What kinds of things are typically included in a memory packet? The sources gave specific examples.
Yes, the nurses often meticulously collect items like photographs of the baby, sometimes taken by professional volunteer photographers, handprints and footprints made with ink or clay impressions, the baby's hospital identification band, the little card from the bassinet with the name, weight, length, a blanket the baby was wrapped in, maybe a little hat or outfit they wore, sometimes a lock of hair carefully tied with a ribbon. Each item validates the reality of the baby.
And the care doesn't end when they leave the hospital. Follow-up is needed too.
Absolutely. Grief is complex and individual. Couples often grieve differently and on different timelines, which can strain relationships. Subsequent pregnancies are almost always filled with intense anxiety. So follow-up support is vital, offering connections to counseling services, perinatal loss support groups. Sometimes genetic counseling might be appropriate if there's a question about why the loss occurred. It's about supporting the long-term journey of healing. Hashtag KTE8 outro. So when we pull all of this together, what's the big picture? I think what we've really seen today is how deeply interconnected all these conditions are. Having uncontrolled diabetes or chronic high blood pressure significantly raises your risk for things like preeclampsia, placental abruption, maybe preterm labor. Nothing happens in isolation. And it underscores that complexity requires incredible precision. From spotting those subtle early signs of HELLP syndrome to calculating that magnesium and sulfate dose perfectly, down to the milliliter per hour, to managing IV insulin based on hourly blood sugars, every single detail matters. Proactive, knowledgeable nursing assessment and timely, accurate interventions are just fundamental to safety in these high-risk situations.
Yeah, and here's where it gets really interesting, I think. The difference between a bad outcome and a safe one, between morbidity and mortality, it often comes down not just to knowing the diagnosis, but to the speed and accuracy of the care provided in those critical moments. Like knowing exactly what to do in order during an eclamptic seizure, protect the airway, don't restrain, time it, administer the mag bolus correctly, watch those DTRs like a hawk for toxicity. It's that blend of deep knowledge and confident, precise action that really makes the difference.
It shows that all the science, all the book knowledge is only as good as its application at the bedside. The human element is critical.
Exactly. And that leads right into our final thought for you, the listener, to think about. We've talked a lot about highly technical, life-saving procedures, the calculations, the drug protocols, knowing not to do a vaginal exam with Previa, the strict handling of methotrexate. But how does this highly technical field manage that incredibly difficult pivot? How do healthcare teams shift from those intense, rapid, life-saving actions to the equally structured but deeply compassionate work of creating something like that memory packet when a loss occurs?
Yeah, that transition.
How does the necessary emotional intelligence allow a medical crisis, sometimes a medical failure, to become an act of dignified closure? How do we balance the immediate need to save a life with the profound long-term needs of grieving families who have to somehow plan for a future after loss? Something to really consider.